Okay.
Let me check it out.
Okay.
I'm fairly sure.
Yeah, because otherwise,
When are you going to work in?
Wow.
Well, what?
You're on schedule working every night.
That's nice.
No?
Not that I know of.
Oh.
And you rent that out when you're
I
not
saw,
there?
I thought I saw your name on the sketch. I said,
So,
you sure?
my wife and I were
Well, nobody sent me any schedule.
Wednesday through Sunday and just slaving away.
I'll have to ask Nicole.
I mean, not that we don't have people.
Yeah.
We have a manager, we have a gardener, but still.
I thought
You can do it as a
oh yeah, he's
Well,
going
not
to
only that, they're just things that no one else does.
Well, that'd be nice if they called me.
Better call Nicole.
Yeah.
And then where's the beach? Is it right out?
The beach
Right across the
is,
street?
it's about a 5-minute walk to the beach. Our condo, which is.
Sydney, how you doing?
It is.
Oh, really?
Oh, really?
So I haven't been to Hawaii yet, so that's my goal is to get there. And then I'll have been to all of these.
No, that's the key to my apartment.
I was gonna say, what good is that for your car? It's gonna be a key for your
You don't need a key for your car. In fact, I can open it with my iPhone because there's an app. I just
course
can't.
there's an
I can't drive it. But I can open the trunk and.
Can you drive by remote control with your iPhone? So sit in the back seat and
No,
just drive it?
but I've left my key in the car before and locked it, and I can open the car with this app. It's pretty cool. You can find out. You know where if you lose your car.
Then we still have to go online and register again.
You have to see.
Call your car to come get you when you lose it. Say, come pick me up.
CME credit.
No.
Well, there's some robotic cars that they're selling now that you can actually buy to drive themselves. Yeah.
The way you did.
I'm not connected to the Wi-Fi.
No, well, I don't want you. So, Drew, what can you do for us for parking? What can you do for us for parking here? Until these 3 buildings are done being built.
Yeah, for another year it's going to be.
It's going to be my 50th.
You don't think we could get an hour parking in the basement? You don't think you could work that out?
Bill's working on that, I think.
Yeah, I asked Bill last week.
I don't get parking there.
You have to park on the street too?
I think you have to win a Nobel Prize again. I'm working on that here. That's my plan.
Oh, a show and tell. My guest on last week's Secret Word, but since it was anaphylaxis, I just put that in and that was the word.
Oh, yeah.
Because I didn't get it early enough to just anaphylaxis.
What was last week's?
Anaphylaxis, I just guessed because I wasn't here early enough to know it, so I just guessed it was
that's
anaphylaxis.
Tennessee.
Well, they let me sign in with anaphylaxis.
They've let you put whatever in. But go in again and put Tennessee.
What gave me my thing at the confirmation and everything?
But they'll look at it and say, I'll tell.
Really, I didn't say anything. I put anaphylaxis.
Tennessee is. Oh, you can put in the wrong word and not know that it looks like
You're not supposed to, but I'll tell these 2.
Yeah, we were the logical guys.
When you talk about anaphylaxis?
You would have been right most of last year.
You talked about idiopathic anaphylaxis.
Yeah. So everybody's still out looking for parking problems?
Yeah, okay. So, where are your people from?
There it is.
Wichita, Neffenbach.
How was your summer?
Sunday night. So exhausted.
We've been to see it. We diving there.
No, just for visiting. No, it's within German carpentry. Cousin that's 94.
Okay. What time is it now?
7.
Right. I'll give it another minute or 2 just because this is not the room we usually use. How many people went to the wrong place this morning?
I would have, except I saw it.
Oh, you
So where are you going, stupid?
found it fine.
Yeah.
Secretary's very
You didn't
good.
know any better.
Yeah, she
Seemed like a great room.
I think Trixie headed everybody off. So.
This room's actually nice.
So we're now playing musical room.
I don't know, for some reason, 3 days in the whole academic year were in this room because someone signed into the other room before we did. You have to sign up for the room.
Too many passwords.
They built it last year.
At least you know to store them in your phone.
Yeah, well, I was-
Steve Tillis said he was coming. Steve was coming this morning, but he's
thought he
going
was.
first, I think.
All this stuff is going on.
Well, why don't we go ahead and start it? I think a few people drifted a little late because they'll probably have a force of habit. Now we can start. Here's Bill and Gary.
Maybe parking up by the Space Needle too.
I don't have any special remarks. Just very pleased to have Jonathan Corren up here from UCLA to talk to us today. He changed his title a little bit. It was originally something like Innovative Methods of Immunotherapy, but he can tell us what the correct title is. The word up here is just a reminder, if you want to get CME credit, that's what you have to type in when you go in to get credit. That's something I do want to talk about. Not very many people are actually using CME credit, and to be honest with you, working with a woman in the UW CME office is such a pain for me. Explain your recording. It drives me crazy. If not enough of us really care about the CME, I might dispense with it. But anyway, Jonathan, thanks for coming. Come on up here and.
I get a letter at the end of the year with my party 3 credits. But I can't get money if we don't have CME, that's the problem.
Do I need to speak directly into the mic? No? Okay. Good morning, everybody. I got here about 6:20, so I wanted to be on time. I thought I was going to be the only one here. I was worried there was no interest in immunotherapy. So what I'm going to talk about are new forms of immunologic therapies for cat allergy. The reason being cat, because we're working on a big study, and I've had the opportunity to learn a little bit more about cat. It's a great model for studying immunotherapy, but it's a little bit different from other allergens that we study because it is mammalian in origin. That can have some very important implications about the human immune response to the protein as well as whether immunotherapy can be truly effective. Let's see. These are my disclosures. Those are the companies that I'm actively working with in research, consulting with, and on speakers' bureaus. So we'll touch on some of the epidemiology and immunology of cat allergy, briefly review some of the proteins that are involved in the process of human sensitization, talk about existing forms of treatment, and perhaps why we need to look for alternatives, and then end up with an overview, which is what this talk is really intended to be, of some of the evolving methods that we're using in the clinic, as well as preclinically, to evoke a better immune response in allergic patients. So we'll talk a bit now about epidemiology and immunology of cat allergy. And I should take a poll in the room. How many people here own cats? I don't think we need to say much more about this topic. So we've learned well that cats are highly allergenic. And in Europe, about 1 in 4 households owns a cat. In the US, a little more than 1 in 3. Dogs equally so. Dogs even more so. So we've got a lot of a lot of animal dander distributed throughout the Western world. And when you look at the actual levels of FeLD1, which is, we all know, is the major cat allergen, although there are other important proteins as well. When you look at cats, you get some pretty astronomical levels, 578 nanograms per cubic meter of air. So this is actually performed by air sampling in homes, but you can see the range is quite large. And when you look at some of the data that Tom Platzmills and others have collected, that you need probably a nanogram per cubic meter to sensitize, and to elicit acute symptoms in the neighborhood of 10, then certainly you're in a neighborhood where you're going to both sensitize and trigger symptoms on an ongoing basis. That becomes an interesting question, because in people who own cats, is there any kind of auto-tolerizing process that occurs? I'm going to talk about that in a moment. If you look at about 25% of homes that don't have cats, in other words, the upper quartile, you see that the range is certainly having the ability to both sensitize and trigger symptoms, not as bad as homes with cats. But if we take this even further, why are these present in homes? Because people go to work where they have contact with other people that have cats. Certainly that's not an issue for this room, since we don't have many cat owners. But when you look at buildings like banks and schools and other widely attended public buildings, you do find levels that are capable of both causing sensitization and triggering. And there have been studies that have been conducted in Europe where taking people, particularly children who don't own pets, but who are allergic to cats, when they undergo allergy immunotherapy using conventional methods, they actually have an improvement. This is not caught on widely in the United States, but it's a provocative and interesting observation. One of the things that we do know is that long-term abatement is difficult once this very sticky wad of allergens is deposited. I used to think cats were affectionate animals. Now I realize I'm just being marked as territory. And there were studies that came out of Johns Hopkins under the direction of Robert Wood that observed that when you took cats out of a home thinking you would drop levels acutely, the levels don't come down for several months unless you rip up the carpeting, do a thorough cleaning, and go so far as to paint the walls to seal in any wall-bound allergen from reaching the patient. So that's what you call the ultimate in environmental control. Just trying to go back a slide. Okay, thank you. So if we turn to the issue of what kind of an allergen load are patients facing, and what kind of prevalences are we seeing for sensitization, and ultimately, what kind of a burden of disease does this actually lead to? That we realize, because FeLD1 is bound to very small particles which are readily airborne, in comparison with things like dust mite, or DURP1 and DURF1, the major allergens from the two species of dust mite, you're looking at about a 1,000-fold increase in the amount of allergen comparing FeLD1, which gives rise to about a microgram per day, which is actually inhaled, and this is in homes with cats, versus an area like Seattle or Los Angeles, where we do have endemic dust mite infiltration in our homes and into our bedding, where you're looking at 0.01 micrograms per day. So a couple of log differences. Part of it not only is the fact that the cat is small and light and airborne and stays airbound. You look at the dust mite allergens, not only do they stay in place in the bedding, but they're very, very large and they have problems penetrating into the lower airway. Now, if you look across studies, particularly in the United Kingdom, and this is referenced from a 1996 article, children in the UK, almost 6% were sensitized by age 4 to cat. If you look across studies in the United States, you're looking at about 1 in 6 people, about 17% are sensitized. So this is something that's extremely common. Some of the studies that have come out of Europe have demonstrated that the single most common allergen leading to sensitization in asthmatics is cat, with prevalences in the asthmatic population up to 60%. It's gone so far as to say that about a third of asthma in the U.S. is now attributable to cat allergen. And this is from Sam Arb's, part of the N. Haynes data. And when they've tried to construct models, they feel that this is one of the allergens, along with dust mite and perennial mold, that are actually leading to an increased state of asthma pathogenesis as opposed to just being a triggering allergen. Now, when we talk about cat, we usually think of FeLD1, which is a heterodimeric protein, a couple of big chains that are not covalently bound. It turns out that in the case of cat, there are other things that are important as well. We know there's lipocalin, One of the members of the lactocalin family with regard to cat is FeLD4, which is thought to be important in some patients. If you just focus on FeLD1 to start with and look at the amount of IgE, it turns out that about 55% of anti-cat IgE is directed against Felis domesticus 1. The range is somewhere between 0 and 100%, certainly leaning much closer to the 100% mark. But there are other proteins where the larger proportion of IgE is actually directed against both FeLD4 as well as albumin. Albumin much less chronically and commonly. In early life, what we've learned is that at moderate to high levels of allergen, there tends to be an IgG4 response. And if we look at people who have later exposure, it tends to be a more predominant IgE response. This is something that we've read a lot and heard a lot about over the past decade. Something that may be much more important with regard to some of the new immunotherapies that are in development are looking at T-cell sensitization. And if we look at cat-specific T-cells as a proportion of total T-cells using tetramer technology, somewhere between 1 in 7,000 to 1 in 300,000, depending on the individual, of their total T-cells are actually cat-specific. Now, if we shift over to something like birch, looking at BET-V1, the most prominent of the birch allergens, we find that the ratio is somewhere around 1 in 200. So we have orders of magnitude difference. And the question is, why? And some of the speculation has posited that these are mammalian proteins. And that, in fact, because of this, there may be thymic deletion of these T cells directed against cat that are recognizing epitopes directed to cat as well as other proteins of mammalian origin, whether it be mouse, etc. When you look at plant proteins, there's such a distinctive phylogenetic difference with human compared with human epitopes that you're not going to see that same thymic deletion. And this is speculative, but I think certainly makes sense. And this may be something that plays very importantly into issues of which immunotherapy will work. Now, tetramer technology becomes important. If we look at a model of a tetramer for detecting specific T cells where the proteins from the native allergen are hooked up to an MHC class II molecule, which then allows us to bind specifically to small numbers of T cells and identify their identity in terms of the antigen that binds and stimulates them. If we compare this with other methods, such as T cell proliferation, we really can't tell the ratio. We can't tell the specific number. And this is something that is of interest. So we know that there's a lot of cats in the United States as well as in Europe. And we know that we instruct patients to do certain things. If we turn to the left side of those small pictures, we've got a HEPA filter, we've got a mop. It looks like it's being held by a small child. Parents believe if he wants a cat, he has to clean his own house. That's a leather couch and a cat being washed. And there was a study done by Tom Platzmills that combined these modalities, where patients had high efficiency particulate air cleaners running at a set volume. They removed all their carpeting, all their fabric furniture, covered everything in a special impermeable covering. And then finally wash cats weekly. And keeping cats out of the bedroom, when you combine all these things, they found that you could get levels of allergen very close to where they would be if there was no cat present at all. However, we know, when you look at that, there are plenty of homes that don't have cats that do have measurable levels of allergen. So what this may do, in fact, is take levels down to a lower level, but that which is still capable of eliciting both sensitization and triggering symptoms. So we take our environmental control approach, which we do try to, good morning, Steve, which we do try to encourage our patients to do. Our specialty is certainly environmental specialty that revolves around the environment. And then we give them some Claritin and an albuterol inhaler and try to eke out some level of satisfaction. And it turns out that it's not a very satisfying combination of things. Even if we go beyond Claritin and albuterol to anti-inflammatories, leukotriene modifiers, etc., that we're still left with people who are markedly symptomatic. Last night we were talking about steroid responsiveness. If you do take somebody who is animal allergic and give them a very good anti-inflammatory, a nasal inhaled steroid and an orally inhaled steroid, and combine them, maybe 2 in 3 people have some satisfaction in terms of the ability to control their symptoms. But fully a third, and this applies not only to animal-triggered disease, but other allergic asthma and rhinitis as well, will continue to have symptoms. So over the past 100 years, people have been experimenting and perfecting subcutaneous immunotherapy. We realize, after many, many trials, that it is the most effective therapy. Roughly 80% of patients will manifest some response, sometimes not very robust, but sometimes almost complete. If you look at the mean improvement in rhinoconjunctivitis, and this applies to seasonal pollinosis, it applies to decimite exposure, seems to apply to cat, you get about a 50% mean reduction in symptoms with a fairly wide range. What's important is that in these people who fail pharmacotherapy, the majority of these patients do respond quite nicely to allergen immunotherapy. And what we've learned is that you get efficacy, which is the first term we define as when you reach a maintenance dose, what we would consider to be a truly effective dose of allergen, you see a diminution in symptoms. But unless the maintenance dose is maintained for at least 2 years, you don't have adequate time to really desensitize the immune system and carry out all of these various functions, such as increasing T regulatory cells and other things that we don't fully understand. 2 years in order to get what we would consider to be persistent tolerance. Once tolerance is established, studies have gone out as far as 3 or 4 years to establish that you still have about a 50% reduction in symptoms several years after finishing therapy. But because it takes so long to evoke these changes, we have a very low level of adherence. And a study came out of the Netherlands recently in a managed care setting, which I think probably the majority of care is in that part of Europe. And there was only about a 20% adherence to a full 2 to 3 years of therapy. And that was for both subcutaneous, slightly less for sublingual, which doesn't surprise me, because I think having to put a tablet under the tongue every day for long periods of time is going to be prone to very poor adherence. But then we turn away from this issue and look at systemic adverse effects, which I think as allergists we've gotten sort of used to that idea. But to many patients, this is not a very attractive prospect. In allergic rhinitis, most of the data suggests a reaction rate of around 1 to 2%. With cluster immunotherapy, it is no higher. You get to rush immunotherapy, it goes up certainly to 20 to 25%. And if you look at the average allergic asthmatic with an FEV1 above 70% predicted, the reaction rates are somewhere in the neighborhood of 20 to 25%, which makes it difficult to treat many asthmatics, particularly if they're more severe. And oftentimes the people we want to treat the most badly have the most severe disease.
You actually think in your everyday practice your adherence rate is 20%?
No, we actually just did a study in our own practice, and we looked at blocks of time, and what we saw was about 50%. I think it's operator dependent. Some of the physicians had higher rates of adherence than others. It's like any other drug that you really have to sort of stay on, though. What have you found in your own practice?
Well, we haven't monitored it, and like many things with adherence, you of course think your own patients are perfect, and it's 100%. So I have no real idea, because we pretty much turn it over to the nursing staff, and you don't
That's
really
right.
follow how many people drop out.
Yeah, I mean, one of the things that may be helpful is to have quarterly visits in the first year. Some allergists do that, others don't. The best adherence data that exists for subcutaneous immunotherapy is about 50%. That's from over the last decade. I think there are ways to improve that. It's sort of like when we examine methods to keep people in studies. What do you do to keep them engaged so they don't drop out? Well, you pay them in that case. I'm not sure that's the right approach with immunotherapy. But having some, hopefully they pay us, having some kind of an ongoing electronic-based and probably phone-based, and some of the things that Kaiser's tried, I think probably help a little bit. But one of the big things may be choosing the right patients. If they really need it, they're probably more likely to stick with it. So there are very few studies in our field. I think about a total of 17 looking at real dose responsiveness to a variety of allergens, to immunotherapy. And these studies tend to state that higher doses are more effective. And when you get to very, very low doses, or even medium doses, whether it be cat or decimite or pollen, you tend to get a much lesser response. And we sort of have taken this for granted now. Although when you look across the nation at surveys, whether people are actually employing these kinds of doses, it's by no means universal. And I think as a specialty, that's one of our challenges, is to break old habits, and encourage people to use these kind of doses that we're about to look at in the next study.
Scary.
This was a clinical trial, a very small one, mind you, but keep in mind that we're looking at fairly precise assessments with high reproducibility, so we may get by with small numbers. Performed at National Jewish, Hal Nelson study with Dr. Nanda as his fellow, and it was a placebo-controlled, double-blinded study, only in 28 patients where they looked at 3 different doses of cat allergen, with the measurable amount of FeLD1 being 0.6, 3, and 15 micrograms compared with placebo. Patients not only had to have a positive skin test defined as a mean wheel diameter of greater than 5 millimeters, whereas some studies had used 3, they had to have a positive nasal allergen challenge, which in this case is the primary outcome for the study. Very interestingly, there has been some data suggesting that in patients with 3 millimeter skin tests, the prevalence of positive immunocaps drops significantly. And there's been some unpublished data suggesting that a positive immunocap is probably more predictive of a positive response to immunotherapy than is a positive skin test. So we'll keep track of that and see where that goes.
What about the magnitude of the immunocap?
Most of the studies have mandated, where this has been employed and analyzed, have mandated a class 2, 0.7 or above. So we don't know about whether class 1s. Once you hit class 2, I'm not sure if there's any kind of a dose response after that. But it does appear that, oftentimes people will not see a positive prick and may even resort to an intradermal, and that may serve as the basis for immunotherapy in some patients and some practices, and we may have to question that whole approach. It may not be very effective. So in this study, they measured nasal allergen challenge, they did titrated prick skin test, late phase reactions in the skin, and they looked at some serum markers. And what we're looking at is the effect of cat immunotherapy on total nasal symptoms. And what we're looking at are the means with the interquartile differences and the ranges marked by the vertical lines. And we can see that for placebo, we get a nice placebo effect in about 5 weeks, but after a year, it sort of comes back closer to baseline. But if we then look at the 3 doses, the low, medium, and high dose, that we don't see any statistical differences in the magnitude of the nasal allergen challenge at the low and medium dose, but we see very profound suppression, not only at 1 year, but starting as early as 5 weeks. So in fact, when I was a fellow, we often were taught that you had to give immunotherapy maybe 6 months to a year at maintenance to really see these changes. But what we realize is the magnitude of the efficacy is really reached very early on. As soon as you hit that maintenance dose, you've changed the T cells, and you start to change the amount of IgG4 that's produced. Tolerance is what requires time. Efficacy requires dose. And we see very highly statistical differences between the 5 and 1 year point and baseline. Now, we continue to use IgG4 as a marker for both exposure to an allergen in its native environment, as well as a marker for immunotherapy. There have been no studies compellingly showing that there's any kind of a good relationship between the amount of IgG4 that's engendered and the amount of improvement that the patient experiences. This may be not because IgG4 is not important, but because of the affinity for the allergen itself. And you may have a range of avidities or affinities for the IgG4, for its target, which in this case is the allergen. And when they have done studies looking at taking serum that contains presumably this IgG4, exposing it to basophils and seeing an amount of basophil histamine release, when the serum is then neutralized with heat, it no longer evokes the same amount of basophil histamine release. And what Steve Durham's lab in England has proposed is that IgG4 is probably very important, and that what happens is there's facilitated antigen presentation, and this is a process that is probably critical. And over time, as you get an increase in IgG4, you get an inhibition of this facilitated antigen presentation by B cells to the T cell. B cell acting as an antigen presenting cell in that case. So if we now, with that as a background, if we look at placebo low and medium and high doses, and we look at 5 week and 1 year into therapy, we see with both the medium and higher dose immunotherapy that there are robust increases in the IgG4, and really with low dose immunotherapy, we're not really seeing much of anything at all. So if you translate these into the kind of doses that we use in immunotherapy, So using the 10,000 allergen unit per mil from any of the manufacturers, we'd be looking at about 0.5 ml maintenance dose using an extract that's somewhere about 2/3 to 100% cat. So if you have a 5 milliliter vial, you put in 3.5 ml of that pure cat, 10,000 AU per mil, and then end up with a 0.5 maintenance dose, you're in the neighborhood of about 15 micrograms of FeLD1. That is a lot of allergen. And when we first started doing that, we were extremely concerned about the potential for anaphylactic events. We have not seen it. We have not seen it anymore. And it turns out that, in fact, it's been estimated by many of the companies that cat is a relatively weak allergen compared to things like grass and dust mites. And if you look at your own experience, I'm willing to bet that you get a lot of much larger reactions with northern pasture grasses and both of the dust mites than you do with cat. So think about that. Now, what about omalizumab, and how does that play into this? There have been some prior studies showing large effects of omalizumab on nasal allergen challenge with dust mites. That was work done by our own group at UCLA, showing about 80 to 90% suppression using omalizumab at the doses that we recommend today. There was a double-blind, placebo-controlled challenge of omalizumab for 16 weeks on cat room challenge. Now, this is independent of any additional immunotherapy. This is using it really as a passive form of immunotherapy where you capture IgE and prevent activation of mast cells. Patients had well-controlled asthma, they had positive skin tests, and they had a positive cat room challenge, meaning they went to the apartment down the block from our office where we kept 2 cats. It's a nice apartment on Wilshire Boulevard. Swimming pool, barbecue.
2 cats.
They never used it, we did though. And they were kept in the room. There's many models of cat room challenges that are conducted, but we kept them in the room an hour if they were able. They were taken out of the room when they reached a 20% drop in FEV1. And they were rescued with albuterol. In this case, 85% of the patients had no regular exposure to cats at home or at work. And this is the data, looking at FEV1 over the 60-minute challenge. On the top, we're looking at omalizumab, and on the bottom, we're looking at placebo. So we're seeing about a 30%, 35% mean drop as we get deep into the challenge. Keep in mind that these numbers are different as we march through, because once people hit, let's say they would go from a 10% drop to a 40 or 45% drop. So they would not continue in the room, which is why you don't see that line continue to plummet. So patients are removed at various times, so the end at each time point is going to vary. But we see at least a 50 to 60% protective effect by the omalizumab. And if you look at the actual numbers for these 2 groups, about 30 patients in each group, chest symptoms were cut by about 60%, rhinoconjunctivitis symptoms by about 50%, and patients stayed in the challenge chamber more than twice as long. And this is using omalizumab in patients who have relatively moderate asthma. But now we get to what's more interesting, which is using this in combination with active allergen immunotherapy. And there are a number of studies that were done primarily in Europe using birch pollen, where they found less systemic reactions and a much higher rate of short-term efficacy. These were not continued out for years to determine whether or not there was any kind of an increase in tolerance. And in the case of dust mite for asthma, patients were studied who had relatively moderate to severe asthma. There was a marked reduction in systemic reactions, but they didn't really look at the efficacy, which was unfortunate. And we believe that this may occur with SCIT by virtue of the facilitation and antigen presentation by B cells, leading to a reduction in Th2 activation. No studies have been done to date using cat allergy. So now we get into this issue of new forms of immunologic therapy for cat allergy. One thing I do want to comment on before we get into this, what's interesting is in our own experience, we've systematically looked at people who have owned cats versus not owned cats, who are both allergic. And what we noticed early on was that many people reported, and this is not early in life, this is people who may or may not have been allergic early in life, but as adolescents and adults became cat allergic. They then, in order to please a fiancé, spouse, or roommate, they acquired a cat that they knew they were allergic to. What they noticed early on was that their symptoms were bad, and in a certain percentage of these patients, their symptoms improved over time. And this has never really been quantified systematically in any real research study. We then studied these patients recently with nasal challenge. and found that the provocative dose, or the threshold dose required to elicit a positive challenge, taking people who were cat sensitive and owned a cat versus people who were cat sensitive and avoided cats, was about a log-fold difference. IgEs were very similar. IgG4 was slightly elevated in the people that owned the cats. But for all intents and purposes, we didn't see a big difference in serologic markers. But there seemed to be the appearance, and it was statistically significant, of tolerance. And what we're going to do now is consider this as we consider new forms of immunotherapy. Can we discover what it is in those 1/3? It's been estimated that 1/3 of patients do this by people I've spoken to, which is completely anecdotal. Yes?
Well, speaking of anecdotal, we've all had patients that swear that's the case. Their own cat, but in the midst of that tolerance, they still have problems around other people's cats. Any clue what's going
that's
on
common,
there?
but it doesn't make any sense.
That may be more psychic than...
Well, I mean,
I think that must be.
but you're kind of validating at least half of
their first observation.
Exactly, which most of us threw out the window for years.
Yeah, and the question is, what is it in those patients that's different? Yes?
Is there any motivation in the industry to change the concentration of the cat allergen?
To make it more concentrated?
Well, yeah, because when I reviewed this last year, I mean, you basically have to have a whole immunotherapy bottle devoted to just cat, or you're not going to be successful.
Exactly.
And then
right.
they tripled the strength of mite allergen. Can they do the same thing with cat?
They could, but I haven't heard any rumblings that this is going to happen anytime soon.
Okay.
Yeah. Good question. So why are we searching for new forms of immunotherapy? Not only for cat, but for all the allergens that we treat. Well, I think first of all, it'd be nice to be able to shorten the required time to develop both efficacy and tolerance. I think on the efficacy side, if we do cluster, we're doing pretty well. But still, the majority of practices do not use a cluster protocol. They use a conventional buildup, and it may take 4 to 8 months to reach a maintenance dose. Secondly, to improve the degree of efficacy. In other words, can we do better than we've done in this 50% improvement? And can we get more patients to long-term tolerance, whether it be in 3 months or 2 years? To reduce adverse reactions, that's certainly still an issue, and I would say particularly in asthmatics. And then finally, to potentially reduce cost, because we know that this is a disease that afflicts both the affluent and the non-affluent, and it becomes a major issue in treating people that don't have the best of insurances. So there are a number of different immunotherapies that have been employed specifically for cat allergy. Number one, altering the mode of delivery. And we're now experiencing that with sublingual immunotherapy for grass and ragweed. Secondly, to conjugate the native molecule to some other molecule that will have an immune modulatory function, an adjuvant, so to speak. Number three, instead of taking the native allergen, figure out which peptides, from 10 to 20 amino acids in length, might stimulate the T cell and shift them to a protective response without actually triggering anaphylaxis and potentially doing it much more quickly. Then, finding hypoallergenic derivatives, taking the native protein, maybe making it into a recombinant, taking out sections that may be a problem, or just cutting up what's there so as to cause less IgE binding and stimulation. This may not cause any improvements in efficacy. This would be strictly for safety. And then finally, something that we're working on with Northwest Allergy and a number of other centers around the country is co-administering the native allergen along with certain cytokine inhibitors that may be instrumental in invoking sensitization and maintaining memory. So let's look first at this alteration in the mode of delivery. Sublingual cat allergy has been studied in one study, which surprised me when I reviewed this literature. We know that the tablets are effective in treating seasonal rhinitis. In the one trial that occurred with cat sublingual, it was with drops. It was a small study, probably large enough as a pilot. But if you look across the literature at the use of droplets as opposed to tablets, the data is what we would say all over the place. And part of that is because nobody really knows what the true dose response is for many of these allergens. And I have the feeling that when you put drops under, most of it gets swallowed quickly, so it ends up becoming oral immunotherapy without the advantage of having any of the mucous membrane in the mouth really absorbing it, if that's a way that it's absorbed. In this case, Dr. Nelson's group at National Jewish used a aqueous cat hair plus pelt extract, 100,000 allergen units per mil, which was the strength at that time. And they slowly decreased it over a period of about 2 weeks from 1 to 20 drops. with a 1-minute hold. Has anyone used drops in their own practices? Okay, we've done a little bit of research with the drops, and when I ask people to put it under their tongue and hold it, and some of the public papers that have been published recommend a 2-minute hold, I'm pretty positive within about 10 seconds they're licking their lips. And they're ready to wash it down with, a Coke. It disappears pretty quickly. I think the tablet may be better. And the question is dwelling under the tongue a real advantage? One way to find that out would be you can measure blood levels of the allergen potentially. Do a pharmacokinetic study looking at these various ways of delivering sublingual immunotherapy, which is yet to be done. In this case, the primary outcome was symptoms in a cat room. So they, again, used a cat exposure chamber. And if we look at the symptom scores, the run-up conjunctive by the symptom scores at baseline in the active group on the left versus the placebo group on the right, there were no changes. There were also no changes in titrated skin tests, and there was no change in serum cat IgG, which was not fractionated. It was all just total IgG, which tells us that there probably wasn't much of an immunologic stimulus in this case, or there should have been a rise in IgG. The duration may have been adequate. Certainly we've seen efficacy with grass and ragweed at 3 months, though no one has really looked at the onset of action for that. And it's uncertain whether the dose was adequate or whether the allergen was really absorbed from under the tongue. So there are many questions, but what we can say at this point is, in the absence of a tablet and a large phase 3 study, there's probably not much to base sublingual drops treating cat allergy. Now, we've talked about and we've read a little bit about intralymphatic immunotherapy, needing to use an ultrasound wand to find the inguinal lymph node. It sounds interesting. And there have been many studies done over the past couple of decades looking at direct delivery of antigen to the lymph node, which, as you would expect, should enhance antigen presentation. You're going right to where we're trying to get when you give immunotherapy subcutaneously. But when you give it subcutaneously, it tends to dwell in the skin. It's ultimately absorbed into the circulation and ultimately finds its way to the lymph node. There are better ways to getting to lymph nodes, which we'll talk about in a little while. They've used RNA, they've used DNA as antigens, they've used proteins, oligopeptides, and what has been seen is there is a strongly enhanced immune response going straight into the lymph node, because you're able to give much larger doses much more quickly. And as we said, this is a dose-dependent phenomenon, whether you get there slowly or you get there right to the top dose initially. There have been a couple of open-label studies of intralymphatic immunotherapy with pollen, both grass and birch, which showed efficacy after 3 doses. The problem was these were open label. They did get quite a bit of attention. But when a follow-up study was published by a Northern European group that looked at grass immunotherapy with a placebo group, there was no effect. So we have to start questioning whether just going right into the lymph node makes a difference. There was also a study that looked at Hymenoptera, but that was in a mouse model. So there's not much to base that upon either. There have been no studies to date with native cat allergy. We're going to get into the cat sublingual therapy study in a moment because it actually combines a couple of different modalities. But if we talk about what are the other ways of altering the mode of delivery, in addition to sublingual, potentially intralymphatic injection of native allergen, there's epicutaneous. I know your Northwest Allergy group has had experience looking at food. And there have been studies showing positive symptom data with 6 weekly patches that were applied in grass allergic patients. That was a placebo-controlled study in about 130 patients. So I think that's something, and that was about a 2-year-old study. We're just on the cusp of that. What may be even more available and more accessible soon is intradermal immunotherapy, where you go right into the skin, where we know the skin drains to the lymph nodes in a much more efficient way than going into the systemic circulation. And it was an observational study in the UK at Steve Durham's group where they did intradermal skin testing. And what they found was that over time, as they gave serial intradermals as part of a clinical trial, they actually saw a reduction in the size of the late phase skin response invoked by these intradermals. And this mirrors data from many years ago looking at the possibility of using intradermal immunotherapy. And there's now a large study ongoing using a small number of intradermal doses to invoke changes. But there's been no studies to date with either epicutaneous or intradermal using cat allergen. So now we'll talk about conjugation of allergen. There's something called modular antigen transporter, or MAT, which was recently published in a cat allergen model. It's based on the idea that in order to improve immunotherapy, you'd like to get more of the allergen into the cell where the action is, and to improve presentation to the MHC class 2. This can be done and has been done recently using fusion of a recombinant FeLD1 to an HIV-derived translocation peptide called TAT, and along with fusion of FeLD1 to a truncated human invariant chain. Not being a protein chemist, I don't fully understand the basis or mechanisms by which they accomplish these, but it appears to have a very powerful adjuvant effect for improving presentation of MHC class 2 on antigen-presenting cells and actually getting the allergen to be taken up into the cytoplasm for processing. And what they have found is in a mouse model of cat allergy, there was an enhancement of B and T cell responses and a reduction in mast cell degranulation. So with that as our background for combining these kinds of proteins to either recombinant or native allergen, there was a study published 2 years ago in the Journal of Allergy, which took recombinant FeLD1, which was mated to this MAT protein, and injected intralymphatically. So we've got 3 interventions going on in one pilot study. A new form of the allergen bound to a conjugated to a protein or a couple of proteins and injected not subcutaneously but into the lymph node. And it was a double-blinded study, a very small study. Patients with cat allergy, they received initially a dose of 1, then 3, and then 10 micrograms, 28 days apart. And 28 days after this last of the 3rd doses, they underwent a number of things: skin prick tests, intradermal skin tests, nasal provocation, and some cellular assays. And what we're looking at is the effect of this molecule, or molecules, on the nasal allergen challenge. And we're looking at the improvement in the post to pre. So if the amount of allergen required to evoke a positive nasal response goes way up, at the end of the study, we should see that this post to pre log 10 ratio should go way up. And that is, in fact, what we see for the active versus placebo. We see an improvement. We see that there's almost no improvement in most of the patients getting the placebo, which is comforting. But we see a variable, in some cases, extraordinary improvement, considering that these are log-based changes in the response to nasal allergen challenge. If we look across some other things, on the far left, we're looking at leukotriene release in active therapy versus the placebo. And we can see that as the doses go up, we're getting an improvement. If we look at ID skin tests, we're getting a shift upward. And if we look at the prick skin test, we're getting a shift upward. So this seemed to be, although it was a small study, we're seeing changes across a number of parameters in the skin and in the nose and in the test tube. And if we now look at the effects of this immunotherapy combination on anti-cat antibodies, if we look at the top 2 graphs, we're looking at IgG4, and if we look at the right, we're looking at IgE. Then in fact, we're seeing a bump in IgG4, and we're looking again at the titer as a post-to-pre ratio, and we're seeing probably about a seven-fold mean increase, which is by no means insignificant. And if we look at IgE, we're not seeing any change whatsoever. If we now look at IL-10 release, performed in vitro, we're seeing marked improvements, or we'll call them increases, in IL-10 on the lower set of graphs.
I think the mouse will serve as a pointer.
Oh, okay. I think I knew that. Right there? Okay, so that's what we're looking at. So this is encouraging. It's a very small study, but using a number of very precise endpoints, I think it leads us to the conclusion that this is worth pursuing, potentially as a way of trying to enhance delivery with a very small number of injections. Other things have been looked at. Andy Sexton's group.
On that, have they continued this for clinical studies, or?
I don't know where this is at in development right now. This is out of the Swiss group, I think. What is this name?
Because
Actus.
I read something about a year ago. They said they were unable to get funding for future studies. So I was wondering. It was very provocative data, but
I don't know if anyone's pursuing it right now.
Isn't that cat allergen 2 peptides?
Uh-huh.
And so the recombinant is both without the disulfide bridge, or do you know what?
The recombinant is, I think, pretty identical.
Okay, so
to
it's
the
full
native
intact.
molecule. It's an intact molecule. You can then manipulate it to make it less allergenic, but the recombinant is presumably intact protein. Andy Saxon was working in a chimeric fusion protein using a piece of the IgG gamma and the FeLD1 together, which seemed to turn off mast cells. People have combined recombinant FeLD1 with dihydroxy D3, which seems to have an effect on antigen. D3 seems to have an important effect on antigen processing by dendritic cells. Carbohydrate-based particles combined with recombinant FeLD1. Hypoallergenic FeLD1 combined with hepatitis B pre-S protein, which seems to reduce the allergenicity significantly, but by virtue of the hep B being immunogenic, seems to maintain T cell responses. And then finally, wrapping FeLD1 in a virus-like particle, Q beta particles. And all of these things have shown promise in animal models and have not reached humans quite yet. And which of these will continue to go on? I know Andy Saxon still has hopes of using their fusion protein, probably not for specific immunotherapy, probably more as a non-specific modulator of mast cell function. And these others, it's hard to say where they are at, and whether any of them will leave the laboratory. Yes?
Is anyone still doing any work with fusing antigens with like bacterial motifs, like CPG kind of stuff?
Yeah, there was a company that was working on that and had published Cytos. And when they moved into asthma, they had a negative phase 2 trial, large trial. I believe that they're no longer in existence. And to my knowledge, that was one of the larger companies that actually had a clinical program looking at using toll-like receptor agonists to try to stimulate responses to antigen. Yes.
Does the D3 upregulate or downregulate this presentation?
It seems to upregulate, so you get improved antigen presentation. That's my understanding. If anybody in the room
So then
knows
we should
more.
not have any cat allergy here at all because we don't have any D3. So we have a population here of vitamin D deficient people, basically.
Interesting.
But they still
Send them to Los Angeles. We'll get them some vitamin D.
I just was curious because everybody I measure is deficient.
So now we're going to talk about peptide immunotherapy, which is probably one of the actual modalities that may reach clinical approval. And we're going to be looking at an in vitro study that actually looked at immunologic characteristics of these peptides. The idea of the peptide being that you'll get presentation to T cells. T cells will then have some kind of a response, whether it be predominantly IL-10, predominantly IL-4/13. I think this is something they're still sorting out. And they actually haven't characterized the kinds of T cell responses that they're getting extremely well. But by avoiding some of the IgE binding sequences, you don't get activation, you get a much safer form of immunotherapy, which allows you then to go to very high doses, those which are probably activating T cells right off the bat. So theoretically, within a couple of months, you would reach doses that would be considered potentially T cell maintenance doses and would be able to stop immunotherapy. In the first study, and this is from Mark Lachey's group, they looked at proliferative responses to a number of different peptides that they had characterized. Some of these peptides were able to bind to a large number of MHC class II molecules, some of them barely bound to any. And then one of the first steps that they would utilize in trying to determine what are the best mix of these peptides is what does the MHC class II binding profile look like. Once they've done that, they go on to proliferative responses, cytokine responses, and looking at basophil histamine release. In this same pilot study, they looked at late phase responses in the skin. If we look across, we're looking at all of the different peptides, which are labeled on the x-axis. And what we're looking at are proliferative responses, and this is a stimulation index. And what we're looking at on the very far right is PPD. Next to that is native cat. Next to that is the vaccine, which consisted of 7 different peptides. And then to the left of that, all of those are the individual peptides. An individual. And what they realize is there's not enough overlap amongst these peptides in order to just include 1 or 2, in order to get really good binding to a variety of different MHC class 2s and really affect proliferation, you had to include a certain number. Now we're looking at cytokine responses to the peptides. And we're looking at the top at interferon gamma, then IL-13, and below that, on the bottom, IL-10. And what we're really looking at is the percent response. That's the clear bar, which is the first. After the clear bar, for each of these different peptides or combination of peptides, we're looking at the number of, or the amount of microgram of that cytokine produced. So let's concentrate on the clear bar. And what we find is we look across at the different peptides, you're really not getting much of a complete response rate. You're getting some response in some of these cells, but as you go to the very far right, what you're seeing is that almost all were responsive when you use Cat or the T-cell peptide mix. And that's what they're after, I think, in this assay. It's just simply to show that these are being taken up by the T-cells, they're being recognized, and you're getting a proliferative response. And the mixture performed far better in terms of cytokine release than the individual peptides. The question becomes, do you want cells making IL-13? Is that a good thing? And this is perhaps why there are late-phase reactions to T-cell peptide therapy, because you are getting activation of clones that are, in fact, Th2 as opposed to T-regulatory. One of the big issues is if you expose the allergen, the native allergen, someone who's can-sensitive, taking out their PBMCs and doing a histamine release, we see across different levels of allergen on the top line, a lot of histamine release. But when you look at the various peptides down below and the mixture of peptides, none of these things is able to bind to IgE specifically and trigger activation of basophils and hence mast cells as well. Should make it safe. And then when you look at the late phase cutaneous response, what we're looking at on the top is the mean reduction in area in millimeters, and on the bottom is the percent reduction. And if we look at the dose of 3.0 nanomoles, which seem to be the best for whatever reason, you see about 40%.
Use the pointer.
Yeah, freeze over there.
Freeze right here. We're seeing a reduction that was statistically significant, and I think more to the point, very akin to what you see with subcutaneous immunotherapy in studies that have followed this as a marker. So if we now turn to peptide immunotherapy and look to see what happens in a real-life setting, in this case using a cat exposure chamber, this was a double-blind placebo-controlled study of the T-cell peptide mixture, the 7-peptide mix that Dr. Larcher had worked on. 202 patients. There were 2 different regimens of giving the peptide, 8 doses of 3 nanomolar, which they had determined might be the effective dose, versus 4 doses of 6 nanomolar with a fill-in placebo to keep it blinded, or 8 doses of placebo. And this was given over a period of 16 weeks. So in 4 months, they are completely immunized. And cat room challenges are done as 3-hour challenges on 4 consecutive days. So if you've ever done a difficult study, I would have to say that this tops it. And they were somehow able to find 202 patients willing to do this. They did it at baseline, they did it after about 5 months of treatment, and they did it after a year of therapy. At the year point, they were down to less than half the sample. And what we're looking at is at baseline, the next line down, being this one, at about a half year of therapy, and at this line, approximately 1 year of therapy. And what we're looking at across, as we go from left to right, day 1, 2, 3, and 4. You can see, interestingly, that if you go down to 1 year of therapy, at the day 1 challenge, you don't see much of a separation between placebo and the 2 active groups. But by day 4, you do see a very distinct separation, which reached statistical significance. This even becomes more profound at the 1 year time point, when they are now about 8 months post-therapy, we're continuing to see either not a significant change, but at least maintenance of where they were earlier. And it's based upon this data that the company manufacturing this drug, I think it's going to be called Polarimmune Cat, or something to that effect, produced by a company called Cutaneous, has gone into a very large trial looking at people who actually own cats, which takes us back to the idea that if people are able to own cats, are they in some way now immunologically different? Have they, to some extent, tolerized themselves? Have they allowed themselves to, by process of normal, natural exposure, able to make more IL-10? These are some of the speculations. So it's interesting that they chose that population. But ultimately, that may be the population that you have to study. There are a number of hypoallergenic derivatives, the goal being really to reduce IgE binding so that you end up with a non-reactogenic molecule. Some of the ways that they've tried this in the literature, a modification of the epitopes by just disrupting the disulfide bonds between the two proteins. Putting in randomly mutated allergen sequences into a recombinant FeLD1. Or even doing single point mutations on this protein side chains that come off in order to try to change the binding to IgE. What they've seen in various combinations of these modalities is almost up to a nearly 1,000 degree of IgE binding with native FeLD1, and still the ability to stimulate T cells. So you may have something that's as effective as SCIT, but will still have to be given potentially. Well, one of the advantages is if you can give large amounts of this quickly, then you might be able to bypass the several week or several month buildup and go right to a dose that stimulates T cells without inducing anaphylaxis. Again, early in development, primarily in mouse models, but something that's interesting and something that may be pursued. And finally, I'll end with what we're working on now, which is that there are some Th2 cytokines, particularly IL-4 and 13, that have been, along with TSLP, upstream from the Th2 cytokines that have been speculated to be important in maintaining a population of Treg cells, or the absence of Treg cells in the case of the allergic person, in maintaining T memory cells for the allergen. And TSLP, which we know is epithelial-derived, seems to have some important effects on polarization of antigen-presenting cells, which seem to shift the presentation of allergens, so you end up in the presence of TSLP with Th2 cells as opposed to Th1. There's an effect on Th2 cytokine release, which was, I think, shown nicely in a recent study in the New England Journal of Medicine, where there was a marked anti-inflammatory effect with anti-TSLP in an early and late phase bronchial allergen challenge model. Although they didn't measure cytokines in that study, that's one of the putative mechanisms by which it worked. And then possibly the presence of TSLP leads to a downregulation of Treg function, although there's data on both sides of this fence. And I think it's not clear yet what effect TSLP has. And it probably has to do with when there's exposure of the system to the cytokine, whether it's early or late. And we currently have a study that's underway, multi-center study along with Northwest Allergy, looking at this combination of anti-TSLP plus SCIT in order to see whether a year of therapy is capable of inducing tolerance. So I think from what we've seen today that cat allergen is pretty ubiquitous and a potent allergen which seems to engender allergic airway disease, particularly asthma. And whereas the conventional immunotherapy that we're using today certainly does a lot, there are some ways of modifying it potentially to increase safety and improve tolerance. And I think which of these immunotherapies we looked at today will make it over the next 3 years is hard to say, but I would probably guess that peptide immunotherapy, if it passes their large phase 3 study, will be the next major change that we have for dealing with immunotherapy. So thank you for listening.
Do you know what the design of that trial will be? Are they going to compare to standard cat immunotherapy or simply?
No, I think it's placebo-controlled. But they'll have historic, controls to look at. We kind of know what the other does. Yes.
Is there a way that they can do this ex vivo and take out lymphocytes from patients and stimulate them in an ex vivo environment, then sort out the ones you want, and not the ones you don't want, and infuse them back in, so you take away the risk of anaphylaxis that way?
I'm not sure anyone's thought of that or looked at that. It's an interesting idea.
This isn't specific to cat, but I've always been frustrated with even traditional immunotherapy, knowing when you've achieved tolerance. I know Steve Durham's paper and others, but in the real world, when I'm advising people at about year 4 or 5 whether to continue or not, I tell them in my experience about 20 to 30% of people are going to relapse in that first year. We really haven't achieved tolerance. And I keep looking for either a clinical or a bench marker to really know who's tolerant and how to advise them. Having just reviewed this whole area, what do you know about that, or what do you say about that?
I mean, one of the things that you could look at would be looking at antigen-specific memory cells. Might be some kind of a predictor of what will happen down the line if you're able to delete those over a period of, whether it be weeks. I would say weeks would be unlikely because of the life of those cells, but certainly over a 3-year period of therapy, that would be something interesting to look at. Whether you could do that using a tetramer technology, I'm not sure. We don't really have a good marker. We have IgG4, and IgG4 is not really a functional assay. It's very much a quantitative assay that tells us how much antibody we have, and it may be the next step over when you're looking at actual function of that. And what the Durham group thinks is probably the closest thing is looking at this facilitated antigen presentation as a functional assay that seems to correlate better than most other things, which will give you a measure of efficacy. But that doesn't necessarily tell you that you're going to have long-term tolerance. There's nothing that I'm aware of that will predict long-term tolerance. I think we don't have a good handle on efficacy at this point, that people will stay on immunotherapy for 2 to 3 years because the standard of practice is if the patient says, I think I'm a little bit better, they'll stay on the therapy. One of the things that we may want to consider, and it's not so difficult to do, is taking one of their allergens, and let's say the big one was dust mite, and you do a truncated allergen challenge in the nose, which is what they're doing, I think, to a much greater extent in Europe now, looking for localized allergic rhinitis. And they're advocating, to some extent, doing this in people who have negative skin tests. Would it be so difficult to do a 30-minute procedure on somebody at baseline, at a year, and at 3 years? And if you're able to show, and then to tie that into longer-term studies. Since skin testing has really not been borne out as a very, very good way of looking at this. The wrong organ. It's a very different immune system than looking at what happens mucosally.
With the peptide immunotherapy in the cat, have they had any serious adverse events yet?
They occasionally get a late phase asthmatic response, because I'm assuming that those people, that particular patient, they're probably really causing upregulation of those cells that are releasing IL-4 and 13. According to Marc Boucher, the current mix of peptides seems to have less, and they're not sure why, has less of a penchant for causing those late changes. They haven't seen immediate anaphylaxis. All they've ever seen has been the late changes, but they think the current mix, I think they're down to 6 peptides now in the current trial, seems to cause less of these late asthmatic changes, so they're feeling better about it.
When he was out last year, I mean, their peptides are 15 amino acids.
15 to 20,
there was a similar attempt in the mid-90s by Immunologic, the Allervax cat.
Immunologic.
Yeah, I think weren't they like 11 or 9 to 11 amino acid? And he seemed to think the length of peptides being longer reduced the late phase reactions relative to because the other company gave up that project.
And the other one wasn't effective either.
Right.
That was
but
part
it
of
was
the
much less well tolerated.
And they got some late phase responses.
And they're about to do phase 3 with this cat thing. So.
And just on the epidemiology, it seems to be that if babies are born in a family with dogs, that they're protected against allergic disease or asthma, but I don't get the sense that cats, it's the same story.
It's presumably the same story. That they get if it's within the first year of life, that they will have this IgG4 response, and that'll be maintained until they leave the cat, and then come back. They lose their IgG4 response, and it's almost like starting from scratch, which suggests to you that the life of these memory T cells, or certainly B cells, is limited. It's not infinite, which is encouraging. Okay, thanks.
All right.
Got 2 more off. peripheral T cells nobody's ever tried that.
Okay.
What about, could you stimulate
Could you stimulate enough to target the problem? To have a full blown total body.
And then another question up to this is if they could stimulate the cells. Have they ever tried doing that using to stimulate the cells with a two-cell stimulus for cat, and then it would give them something like in your hand, take out all the and see if you could wipe out the
Yes.
You could probably, I'm sure you could do a nice to make it perfect.
And then,
I had to review this cat immunotherapy stuff last year. It's just nuts.
It's a huge, it's a high cost.
Now, the study that
It
they
is
did,
pretty high dose.
Oh, yeah, yeah. It's
the
like,
study they did in National Jewish said they had 100,000 units, but the standard stuff was
That was a different standardization.
it wasn't.
That was, yeah, that's 20 years ago.
Okay, so that's not.
But it's presumably around as close. And
That may be within the, because I was putting people up pretty rapidly right now.
Thank you very much. That's awesome.
2 years ago. Thanks for coming.
Nice to meet you.
So that's what we.
You and I both did.
yeah.
It's no way.
It's a great idea. It's just too late. That's perfect.
If you need samples, a couple, let me know. First of the year, because we're trying to